Welcome to a webinar on value-based payment for primary care and behavioral health practices. This is the 6th webinar in a series brought to you by Millennium Collaborative Care and community partners of Western New York. We are thrilled to be able to offer a candid and insightful interview with Dr. Joe Stankaitis and George Hughes. As we get started here, I wonder, Joe and George, if you could both just introduce yourselves and tell us a little bit about who you are and what your background is.
Okay, I'm Joe Stankaitis. I'm the Chief Medical Officer for the Monroe Plan for Medical Care in our health plan, which is called Your Care Health Plan in Western New York. I've been involved with managed care going back to 30 plus years. I'm a board certified internist. I have my master's in health policy and management from Harvard University, and have been intimately involved with a National Committee of Quality Assurance going back to its inception in 1991, and am involved with several of the committees and the groups at the New York State Department of Health that involve themselves with benefits assessments and several pilots. We currently have a grant from SAMHSA to address medically assisted treatment of opioid use disorder in Erie County. We're working with the Greater Buffalo United Accountable Care Organization in that endeavor, and we're really delighted to have a chance to chat with you folks today.
Good afternoon. My name is George Hughes, and I'm the Senior Vice President for Contracting and Fiscal Operations here at Your Care and Monroe Plan. I've been with Monroe Plan for a little over 16 years now. Prior to that, I was in the finance and contracting areas at a federally qualified health center, which was also a sponsor for a prepaid health services plan in Syracuse, New York. So just about 26 years of experience on both the provider side and the plan side.
Oh, fantastic. Well, thank you for joining us today as we talk about value-based care. And I wonder if you can share with us, as you look back over the last 3 to 4 years of value-based care and population health here in Western New York, what do you see as your biggest success and perhaps most important lesson learned?
Well, we're going to go in reverse order, and our lessons learned in starting out with our pilot program with the Jabaco ACO, which also included two health systems, was getting on the same page language-wise with merging the provider side with the plan side on the language we're using. And some of the biggest examples of that was IBNR, the incurred but not reported claims concepts, and how the accruing of claims doesn't necessarily coincide with what a provider might be seeing as far as claims paid go. HEDIS core rules, there's many rules, and I'm going to kick that right over to Dr. Stankaitis on how the whole education and language behind HEDIS core with how a plan looks at it versus a provider worked. Joe?
Well, the thing is that the key thing is to really all get on the same page with common targeted measures and all that, so you don't have multiple metrics that are conflicting and all that. For example, the DSRIP has a whole set of measures that it needs to perform against. The health plans do too. So what we've tried to do is to sit down with the various groups that we are trying to develop value-based payments to kind of work with them. Okay, what makes sense? How can we, both parties, do better as a result of the activities? And then trying to support the clinicians in doing the right thing, which they all really want to do. But at the end of the day, sometimes it's the systems that need to be changed or the processes of care. And, you know, we're willing to really work with the folks on that.
Yeah, and I think to just round out this first lesson learned on the language and just speaking the same type of language in the insurance concepts is the whole idea of the attributed members and how plans assign members to PCPs because in this space, especially with the Medicaid managed care population and the HARP population, we have many members when they enroll do not pick a PCP. So plans have to assign those members based off state regulations to PCP. So understanding that attribution method to PCPs that may never have seen some of our members and how that member ended up being assigned to their PCP is important too. And then on the financial side, with a value-based total cost of care agreement, it's very important to make sure providers understand how the premium rate setting process at the plan level works, how risk scores at the state level may increase or decrease some of those premium rates, and then how the state constantly adding benefits into the managed care benefit packages impacts premiums and impacts how providers have to practice. So that's the first concept of our lessons learned, is spend a lot of time upfront and all throughout on the language. The second big lesson that we learned, and in my notes I have it titled data, is there has to be regular and when I say regular, I mean monthly, if not more than monthly, communication sharing on the communications and data sharing, especially on the quality metrics and the progress on those. So Joe, I'll turn over to you what you guys do monthly with the HEDIS core and other data sharing that we currently do with ACOs and other providers.
Well, our medical informatics group has developed a data warehouse that they're able to extract the data on a monthly basis or as frequently as needed. And they're able to put it in what I think is an incredibly digestible approach. They use Tableau to be able to display how various practitioners or practices are performing against a given agreed upon metrics. We're able to let them know where the gaps are occurring for care so that it can be potentially actionable at the practice level. And again, it's really important to be able to better understand like who within the arrangement's doing well so that you can share best practices with one another. You're all in this together. I would think, like when you're looking at the total care cost, particularly if it's like within a given entity, that it has a value-based arrangement, and that can enhance patient care and get better outcomes.
Yeah, it's been interesting. One question we get a lot, especially early on, when whether it's large total cost of care models or more targeted with smaller practices on the value-based side, is, well, will you share our data with us? And that's, with our historical Monroe plan hats on, started by providers, board of directors, primarily physicians, has always amazed us, because our attitude is the claims data that we receive belongs to the providers. It doesn't belong to us. We use it to pay claims, obviously, and for all of our other work, but the not sharing of data back to providers, to us, just will never happen, because it's just, it has to happen, because the clinicians, when they do see that data, are also going to have more inherent knowledge of what's going on. And what we have found is when we share the data back, especially data from outside the provider office, about what their attributed members are doing once they're out in the community, and some of the RX utilization that's going on, they have a better idea of how to better manage that member's care and reduce costs when they see some of the utilization patterns that are going on. So again, data for us is everything in these arrangements, and sharing that data is like number one on the priority list.
Let me jump in and ask you two. I think they're questions, maybe they're points that I'd ask you to sort of comment back on. One of the things that I think has been interesting, and this is the last in our series of really doing these like podcasts, It's been interesting that we've done these with a primary care physician, with somebody in the behavioral health area, and it has been interesting that one of the common lessons learned really has been language. And I think when we all step back and if we all listen to all of these, sort of hearing that from all of the various perspectives, I think is really shows that we've made significant progress on that. So, I just want to sort of share that observation. The other thing that I think is a real indicator of some of the things that you're talking about is that when I think back 3 or 4 years ago to in some ways the real disconnect in a large way between community-based organizations and primary care practices, within the last month or two in Western New York, I've heard a community-based organization that's partnering with a primary care practice to help them really look at engagement, to help them, and they actually use this language, clean up their denominator and figure out if individuals really are interested in being assigned to this particular practice, and looking at attributed members. And there was a part of me that stepped back with pride, even though I had nothing to do with it, just saying, wow, we have really made a difference, and we are working together differently when a community-based organization says they're cleaning up a primary care practice's denominator. And I don't know if you have any comments on that.
Well, not only that, but I think the more that we can possibly integrate behavioral health care with the physical medicine, the better off everyone's going to be, particularly the population that we serve being really an underserved population under Medicaid. You can come up with the most elegant care plan for someone with diabetes, but if they're homeless, if they have severe mental illness or whatever, it ain't going to work. And we really need to be deliberate. And I think this is where we're making moves in that direction to be able to better integrate the care. If somebody needs behavioral health services, if they're co-located at the practice area or really nearby, to be able to get them engaged right away, that can make a huge difference in terms of what goes on. Particularly for the outcome for the individual and just their overall welfare. So I think that is really like the change that I think we're hopefully seeing slowly occurring, and time has come.
Yeah, and I'm sort of along with you, Kristin, chuckling about cleaning up the denominator, because that is the biggest area that we grapple with, has a plan, and I don't think we're alone, has a plan that grapples with the whole PCP assignment issue, because that's really what happens with the denominators is, when providers know who their members are, and they have plenty of time to work with them and get them in, and again, in the Medicaid managed care world, we understand our members are not the most compliant, as you might see in a Medicare or a commercial world. So, when we assign members or auto-assign members to a practice, no matter what that auto-assignment algorithm is, there's somebody landing in a denominator that a provider may have been totally unaware of, especially if we're all not on top of the attributed members. So, yeah, like you, I'm sort of smiling about cleaning up the denominators, because it's tough. We know it's tough on the plan end, and now when we're putting providers at risk, and there's members in those denominators that they had no idea were in there, or they landed in there in 3 months from the end of the calendar year, and what are they supposed to do then? They're going to have a difficult time getting them in for preventative visits or other related visits that they might need, and it becomes difficult. So yeah, I think that is one area that all of us, especially on the plan side, can do better.
Actually, what's interesting is the community-based organization, and it really was a grassroots community-based organization that I'm referring to, really saw that as an opportunity, an opportunity to begin to work with a primary care practice and work with a plan. And so I think that's a great example of a challenge creating an opportunity for us to connect in these partnerships between behavioral health and primary care and community-based organizations. I wonder if you could share when you say, your note with data. Are you seeing any, any sort of balancing or equalizing of the data that you have in the primary care area and that you have in the behavioral health area? Since we sort of have both of those populations who are listening to this, is your data much more advanced for the primary care practices than it is potentially for your behavioral health partners? Or can you comment on that?
Well, I think part of this gets into, like, for example, we have, as a health plan, because we have a health and recovery plan, have a whole separate set of metrics that New York State Department of Health has given us to meet, which some of them overlap with primary care, some of them do not. I mean, they get into some measurements looking at, which we don't collect, but OMH does, looking at contact with the criminal justice system, things along that line. However, there are some commonalities there, particularly for people that are on psychotropic drugs. Are they getting the appropriate screenings that they need to have vis-a-vis diabetes and all the usual standard preventive services that all these folks need to have. So I think that one of the really big challenging thing is to have everybody on the same page together, because if, say, you've got someone that's got schizophrenia and they also have diabetes, and you have the psychiatrist increasing the dosage of the antipsychotic, but the primary care is unaware and they're scratching their head, gee whiz, the A1C is not moving anywhere. As long as people can talk together and really work with the individual to come up with a plan that would be workable for them and acceptable for the individual to follow through on, that can make huge differences. If you look at the community-based organizations, reason why a lot of people are frequent flyers going to the ED is that, I mean, you live in Buffalo, winters aren't really gentle compared to what they are in San Francisco, but I mean, you're going to have people rationally going to the emergency room because it's nice and warm. They get fed there and whatever. So if you don't address their housing issues, that's going to happen over and over. And if you're in a situation with a value-based payment program with total care costs, that's one way you can blunt that cost in a tremendous way and have that individual be in a more stable living situation, and they can then address their other clinical problems. So, I mean, that's part and parcel of this.
Yep. Well, let's move on to sort of what are you working on now? And this can be a little bit of, we've just reflected on some lessons learned and sort of caught up to speed on that. Sort of what's on your to-do list now? What's something that might be new that you're moving forward with? Give us a sense of that if you can.
Well, the next versions of our VBP agreements, we're moving to add the HARP population into those agreements and not just have the Medicaid managed care for the very reasons that Joe just described. Plus the way the eligibility works. We have many Medicaid managed care members move over to HARP because of their conditions. So we think it's important when we do the VBP agreements to also have HARP included in those. And Joe, I'll let you talk about you did a little bit on the mental health and substance abuse issues, but the opioid, if you want to expand on that.
Yeah, that's huge. I mean, given the fact that, again, if someone's got a substance use disorder, they're not going to pay much attention to their other comorbidities that might be related to physical medicine issues like diabetes, heart disease, COPD, conditions like that. So, and we're in the midst of a huge opioid epidemic, whether we want to believe it or not. You open up the obituary pages and you see kids in there and all sorts of ages of people showing up in there. So I know there's a huge emphasis now to outreach these folks, try to engage them in care. get them into medically assisted treatment. And I think that's something that we as a plan would certainly support. I think it's an important part of the well-being for those folks. That all said, too, what we're looking at is, okay, we're dealing with total cost of care. The number one driver of costs for every health plan in the United States today is pharmaceuticals. And I think that one of the things that when we get into a value-based payment arrangement is to really partner with the clinicians in terms of informing them as to what the real costs are for some of the medications that they are prescribing and what would be an appropriate approach to get the outcomes that you want, but to be really smart about it fiscally. I can give you one example. We discovered, this was about a year or so ago, that metformin, which people who have type 2 diabetes should be on, there was a generic metformin extended release that cost $150 per month, when the generic metformin was really 10, 15 bucks, if that, per month. And the deal was if someone on the extended release wasn't doing well, what the FDA insert said, well, then you ought to put them on the regular metformin and double it up. When we shared this with some of the docs that were involved with our value-based payment, the light bulb went off. Said, my goodness, we can do better with this. And consequently, they were able to decrease their drug costs, like just simply with that particular agent. They looked at several others. And I think, again, if it's a partnership and we're working together mutually to better inform folks, you're going to have a lot more success than if I, as a health plan, am making these changes unilaterally versus engaging the physicians and the prescribers in terms of what might make sense and they can buy into it.
Yeah, and to elaborate a little bit on what Joe just said about the RX costs, what we've seen within the ACO because of that identification, and it's not only limited to the drug Joe talked about, but we've seen a reduction in pharmacy costs within our value-based contract that exceeds the reduction in pharmacy costs we've seen plan-wide. And what we're going to try to do is build off that success of the RX, which was a large one, but we have other benefits out there that when the practicing clinicians and the ACO members have seen it, have said, "Whoa, this doesn't make sense." A big one is also the consumer-directed care, which every plan statewide has seen exploding because it was one of those benefits that the state had. They put it into the managed care benefit packages because it was just too difficult to
They never managed it.
They never managed it, so they've left it up to the plans to work with providers via the value-based agreements to bring those costs down. And we've had our clinicians say, it's the whole auto-approve type thing when a referral is put in front of a PCP, and it's consumer-directed care. What's behind that and why? And in many cases, it ends up services that lead to fraud, waste, and abuse. So the on the ground practicing physicians are the ones that are picking up some of these costs, and it benefits them through the total cost of care model in addition to the plan. So that's one of the key things we're building off and working on as well in our future VBPs.
The other thing that we're looking at trying to incorporate is the telehealth services. There's some great opportunities there. I think particularly on the behavioral health side, if say you're dealing with people with severe mental illness, many of them are asocial, they don't want to go out. We're encouraging, and we're about to launch coverage for telehealth, telepsychiatry visits for some of these folks that have made themselves homebound, and consequently, I'd rather have them have that service than no service, particularly, given their state of affairs. So we're exploring all sorts of venues in terms of enhancing that, medication, monitoring, things of that ilk.
That's great. And also just to reiterate, because we are wrapping up this series, we did do one session around some of the new guidance that the state has issued around telehealth, and really applauded the fact that the sites have expanded from sort of one licensed site to one licensed site to to an array of sites where telehealth can be brought to bear. So I think that is something that's really, really exciting to hear. So why don't we then, we've spoken a lot about sort of the connection and different things that you're working on between primary care and behavioral health providers. I wonder if there's anything else, because one of the things I would share with you is, as I'm talking to either primary care practices or behavioral health, I tend to hear the following statements. I tend to still hear from primary care practices, I really am having a difficult time finding access to behavioral health care. And quite often I'll hear from my behavioral health folks as well. I'm having difficulty accessing primary care for my individuals who have a very significant mental illness. So I just wonder if you can sort of expand on what you're looking at in terms of telepsychiatry and integrated care. What would you like to see from the community in this area?
Well, I think that there's been a change in terms of the way the behavioral health entities are practicing. I know, like, for example, in the Buffalo area, there's three entities that are certified community behavioral health centers. It's part of a waiver that the state of New York got, where they have enhanced payments for delivering care for individuals with mental health issues. And I think leveraging off of that, if we can get creative. Now, when you get in a value-based payment arrangement, I think, depending upon who's involved with it, there's opportunities there to potentially co-locate behavioral health therapists in a primary care setting, and then vice versa, be able to provide primary care services potentially in a behavioral health setting. So I have always hoped that was something that was going to come out of all of the disparate activities. And I think it's going to take a while to evolve to that. But I think we're starting to see some practices actually bring on board staff people from one of the behavioral health centers to actually be on site, so it can facilitate that handoff exchange in terms of, say, the primary care individual seeing somebody that they believe they're going to need help and assistance to better manage. They can get them there relatively quickly. Again, this isn't going to change overnight, but I think we're seeing an evolution occurring with that. I think, again, the telehealth services, that I think is going to open up the door too. So at least you can have individuals getting care that they typically did not have access to.
And I think connection to health homes is very important too. From a plan perspective, we probably have, are we up to 50%, Joe?
Yeah,
50% of our members are connected to health homes, and that's where, in theory, and we do see it in practice a little bit with some of the results that we've seen, that's going to serve as a conduit for that connection between primary care and behavioral health as well, especially with the HARP members.
I mean, right now, at least our health plan's got the highest engagement rate for health homes with people that are in the HARP program. So
yeah,
in New York State. So I think that's been a real plus. And I think, again, the more we can help these people get engaged, get the services that they need to address their social determinants, for which a lot of them really have great needs, I think we're going to be much better off.
And we do see with those members, we do see lower than plan-wide ED utilization rates, right, readmission rates, and other district-based metrics. So we are seeing some successes there as well.
Oh, that's great. Oh, you sort of talked about social determinants of health. You know, do you have thoughts as we do think about housing, as we do think about food, about a variety of those social factors influencing our health outcomes? You know, it's a pretty broad question to say, are we doing enough? But I wonder if you can talk a minute about sort of what your experience has been in addressing social determinants of health and what you see perhaps in the next year or so coming down the pike.
Well, I think a lot of this, as George alluded to, ties in with your health homes. I mean, that's where they've got, I think, the portfolio readily available to them, hopefully, of the various community-based organizations that can provide services such as housing, helping them out with food and the like. However, I mean, we need to build off of that. And unfortunately for health plans, I mean, we don't, well, I think it's gotten interesting where the state starts, well, they're starting to believe that maybe we're like the biblical story of the 5 loaves and the 2 fishes. I mean, they're not funding a lot of stuff and they're expecting a lot to happen. But I mean, you see some groups that are really doing some incredible work. You take a look at, for example, for opioid use disorder in the Buffalo area, you've got a group there, Saving the Michaels of the world, that are providing transportation to get people to the appropriate services that they need for their substance use disorder. I mean, that's a plus. That's a step up and all that. So again, this is something where I think various practices can explore. Again, work with the health homes too. If, say, for example, you've got a cadre of high-need individuals that would qualify for health homes, I think a lot of the folks that are enrolled in Medicaid at the end of the day can find themselves eligible for it. That would be the way to really leverage off of that service within our community.
Yeah, and outside the health home realm, the state did allocate funds to plans that, and it was either use it or lose it type funds for the home and community-based services to go out and contract and get RFPs from some of the HCBS type agencies, which have elements of the SDH in them. In our case, we've contracted with approximately 6 or 7 agencies, I believe it's 7, to provide HCBS services that have metrics tied to them. And in order to claim all of the funds through the mini grant that we did, does have those SDH elements in it. And more importantly, it's going to have a lot of learnings for us. Has a plan on how to get out there with the CBOs, with covering the SDH type services to see how we can possibly manage them and to help them get into a managed care type mode as well, learning how to work with plans and other providers of service on those. So that's going on in the next year. So to answer the vague question of have we done enough, I would say at the state level, plan level, probably not. But I think in 2019, 2020, there's going to be a definite uptick and everyone's learning on what to do with those because of that HCBS money that was made available to plans to go out and contract with the CBOs with.
Oh, that's terrific. Well, I would really like to thank both of you for sharing your time and insights with us today. It's been great to hear about the Monroe Plan's work, and I thank you for taking time to be with us on the webinar today. Thank you.
Thank you for having us.
Great, our pleasure.